I want to start by thanking the All Ireland Institute here and the Institute of Palliative Medicine in Kerala for just enabling this visit to happen. It was an incredible privilege, and it has proven to be incredibly fruitful in very unanticipated as well as anticipated ways, and I might refer to that later. So my interest in Kerala was driven by an interest I have in palliative care as a public health challenge. So what happens, how are we going to manage the baby boomers, of which I am one, as we move into our 60s, 70s and 80s with advanced chronic illness? We're more likely to live longer. With advanced illness, we're more likely to have one or more advanced illnesses, and we're more likely to live longer in much more ill states. And I think any health system in high-income countries are struggling to know how we're going to deal with this. So that was my interest in Kerala. So just by way of background, India is a federal state system, so it's 21 states, of which Kerala is one. So in other words, the states are self-governing, much like the United States. Now, Kerala is that little red strip down at the west side of the finger of India, so it's quite tiny compared to the other states, as you can see. India as a whole has about 2% coverage for palliative care. And not only that, but India has probably the most draconian regulations in the world around the use of morphine. It's essentially not available. So the plight of people with advanced illness who are in pain, it really doesn't bear thinking about. Now, Kerala is the exception, but Kerala is an exception in lots of different ways in India. So in Kerala, which as you can see is quite small, Kerala has a population of 33 million, which is about 3% of the population of India. Now, Kerala is about 36,000 square kilometres for its 33 million people. Ireland is over 70 square kilometres. The Republic of Ireland is over 70 square kilometres, right, for its 4.5 million people. And I think we're crowded. So, it's quite densely populated. It has, in contrast to the rest of India, it has about 70% coverage for palliative care. And since 2009, it has a palliative care morphine policy that has made morphine pretty readily available, although doctors have to get particular training for prescribing morphine, but that's readily available as well. So how did this all happen? And it's attributed to what we know as the Kerala model, which came out of North Kerala. And in North Kerala right now, the palliative care coverage is in the region of 90%. So compared to 2% of the whole of India, it's a stunning success. What happened? Well, two anaesthetists, one of whom is Suresh Kumar, who continues to be the face of the Kerala model. They, between 15 and 20 years ago, became so frustrated at the plight of patients that they were seeing that they looked for something very radical, because the health system didn't have the capacity to address the care needs of these patients. And the idea they came up with was that they would train a very small number of volunteers in the vicinity very close to the medical college, which is where they were based. And they trained these volunteers basic care skills. What is meant by palliative care, the principles of palliative care, and they trained them in basic communication skills, and sent them out. And what they said to them was, we will now refer patients to you, but we would also like you to identify patients in your community who you think have palliative care needs based on your understanding of palliative care and the principles of palliative care. Mm-hmm. And off the volunteers went. And there were a number of lessons that were learned very, very quickly. Firstly, these volunteers had absolutely no problem in providing the care that the doctors had looked for them to provide for the patients to whom they referred, they referred to the volunteers. Secondly, these volunteers had absolutely no problem in identifying patients with palliative care needs in their community. Thirdly, a communication pathway was set up by the doctors so that these volunteers had access to the doctors by mobile phone pretty much 24/7, and that would be for clinical support. And that, when I was over there, that communication pathway is still the kernel of the program, and it's deemed to be sacrosanct, and you could see it working, but it was set up straight away. But the volunteers recognised very quickly that that clinical support was only going some way to meeting the needs of the patients that they were identifying and seeing. That when they applied the palliative care principles, they were seeing, and they used the term continuously with me, they were seeing suffering. So how are they going to address the suffering, the impact of illness on families? And they did this by their own initiatives. They started going out and meeting business people, business leaders in their community, religious leaders, any community groups that they could find, their friends, and they started looking for ways, ideas as to how they might address other needs of these people. And these needs ranged from financial crisis resulting from illness, to not having the resources to get to hospital, to pulling children from school because they just couldn't get the children to school for all kinds of reasons. And the communities responded very quickly. And so a number of programs emerged very early on, like sponsoring children to stay in school, like sponsoring families to get them over crisis, and so on and so forth. But the communities then began to ask questions themselves, and they were asking, well, what is it that we need to do to get palliative care going here? And they began to look to see how they could influence and shape palliative care. And so directly from that work, you can trace the establishment in 2009 of the policy, the government policy on morphine regulation, which broke all kinds of ground with in India. This clipping that you see here is from a newspaper clipping, and this is another indication of the kind of the success of these volunteers and the communities. This, I think, is 2012. Yeah, it's 2012, and this is where the government in Kerala just have made palliative care a primary care, part of primary health care. And what that in effect means is that any service in primary care which is looking for resources or applying for anything to government, resources, service development, whatever, the question back to them is, what are you doing about palliative care? I don't care what you want to do, but what are you doing about palliative care? So it has really put palliative care very much on the policy map. So from the work of those early volunteers, the Neighbourhood Network for Palliative Care was born, and there are now about 10,000 patients at any one time for the Kerala model, and about 5,000 volunteers. So to support that, they put in a number of structures. So the Pain and Palliative Care Society was set up by a number of people with shared interests, including these two anaesthetists. And from that palliative care clinic set up, Pain and Palliative Care Society set up the clinic, took over the governance of the Neighbourhood Network, and also set up the Institute of Palliative Medicine. And the Institute of Palliative Medicine was set up in 2003 as the training hub for the volunteer programme. And it is stunning the amount of training programmes that they're running and the creativity around those training programmes, and we have so much to learn from them. And I will come back to rehabilitation and mental health later. So the Institute also set up specialist palliative care programs. So they have a specialist palliative care program for allied healthcare professionals, which in truth is nurses. And I met the very first community physiotherapist to be appointed in palliative care in India. And that was she was only literally just appointed when I was over there. There's a specialist program in palliative medicine, and those two specialist programs compare very favourably with our specialist programs, except they're run very intensively as residential programs over 8 weeks, and they are incredibly intense. There are about, as I say, 5,000 volunteers who are active. By active, I mean they're providing at least 2 hours service every week. I met a teacher who's a full-time teacher, male with his family, and who was providing 15 hours a week as a volunteer. And it was just amazing. As a consequence of the community activism, there's been a drive for government hospitals to second staff, nurses and doctors, to work as in the home care with the home care teams, and also to staff palliative care clinics. So that's been happening, and there's about 50 doctors, most of whom are part-time, and about 80 to 100 nurses working across northern Kerala on this. Now, as a consequence of the community programme, I said there was about a 70% coverage in Kerala for palliative care. A load of other programmes have emerged in other parts of Kerala. So mimicking what is the Geralyn model. The training and support for the volunteers, the very basic training is 16 hours theory and 4 days practical. I attended there's a volunteer subgroup in the EAPC that's kind of looking at really volunteers, hospice volunteers across Europe. And I met, at the EAPC conference, I met with volunteers from Austria, Netherlands, Germany, Italy. And their training is actually quite similar, which is kind of interesting. Half of the training in Geralyn for volunteers is devoted entirely to communication skills. And one of the things that they found that they wanted to look at was how do you embed, how do you work with this communication? And one of the things that really surprised me was, and this was one of the unanticipated consequences of the visit, I have just completed a 2-year training program in logotherapy and existential analysis from the Viktor Frankl Institute, and just submitted my thesis actually. And that was on my CV. I'm not sure whether the Institute sent my CV or I sent my CV, but also on my CV is my action research background. And I knew action research is huge in Geralyn I worked in development in a past life. So I thought that's what would catch their interest, but they couldn't have cared less. It was the logotherapy, and they had all read the senior management people and the senior professionals, the doctors in the Institute of Palliative Medicine had read and looked at Viktor Frankl and how Viktor Frankl's ideas could be embedded in the volunteer program, which kind of blew me away. And so we were really starting in the United States. So we ended up doing a day-long fellowship, a day-long seminar as part of their fellowship program on logotherapy and existential analysis. But they would see that as really important. That kind of work is really important to the role of the volunteers, which is kind of very interesting. So what did I want to do? I wanted to look at the governance for this program. What were the support structures in place? Who are these volunteers? What exactly are they doing? What's their motivation? And how long are they working as volunteers? And I wanted to know about sustainability and what kind of sustainability issues there are and how they're being addressed. And I said to you earlier that Suresh is the face of the Geralyn model, and that's certainly one of the sustainability issues that I think could be raised. I was really lucky, and it was pure luck, in my timing for the visit, which coincided with one of their annual events, much like what's happening this week here in Ireland. They have a Palliative Care Week, Awareness Week, and it's huge. So they have these huge political rallies and they have meetings of volunteers, and that gave me great exposure to a lot more volunteers than I could have possibly hoped for. So this is one small area of a community in a small suburban town in northern Geralyn. These are the volunteers. And they're listening to various people giving them updates on policy. I met with volunteers. I shadowed home care teams to look at the interface between home care and the volunteers. I shadowed volunteers who are also staffing in the clinic. They don't worry terribly about confidentiality. I met with the trainees who were attending various training programs in the Institute of Palliative Medicine, and the photograph here is a group of the most delightful students from the different colleges. They have a Cambridge, Oxford kind of college system, so I think these were from engineering college actually. And they're students, but they're also very experienced volunteers, and they were doing a train the trainers program. And one of these guys is a mathematician. Isn't that amazing? I don't know why it should be amazing, but it seemed amazing. So I want to finish by focusing on my learning points. These are just 3 I've brought for today. There was a lot more that came out of this. So the first is a social model. I knew from reading, doing a lot of background reading on Geralyn, that there was some disquiet about how a social model is defined, say here, the emerging compassionate communities in the UK. So I was sensing that there was a difference, and I wasn't sure I fully understood that difference from reading the papers on it. But I learned, and I kind of really got to a sense of that difference. So the social model from a Geralyn perspective is a model of palliative care that is completely driven and shaped and owned by the community. They are driving healthcare policy. They are driving any service development that's going on in healthcare. They are driving it. It's not, as in the Compassionate Communities programs, where the communities are being brought in to a health service model, even though the kind of philosophy of community participation is very much prevalent in the compassionate communities. So it was kind of getting a sense of that was hugely important for me. And one example of this was a couple of volunteers I sat down with at one of these functions, and they said to me that they actually attended meetings with local government agencies, and they were saying to local government agencies, you don't need to worry about us, you need to leave us alone, we can look after palliative care in the community, we need you to start looking at the hospitals and start looking at primary care and get the staff in place. And I said, well, that was very novel of you, and I know you're self-financing and through community contributions and everything. That was great. And they said, no, you don't get it. We want to own our community participation. We want to own palliative care in the community. We actually don't want them coming in. And that was the click, the light bulb click for me when I kind of got where they were coming from. They have, and a number of programs have emerged from the Geralyn model through the Institute of Palliative Medicine and driven by the community activists, one of which is they now have a program for mental health, which we're kind of teasing out a little bit in the School of Nursing and Midwifery, that people with enduring mental illness, they're now actually looking for a volunteer model to support that based on the Geralyn model. And that program is now housed by the Institute of Palliative Medicine, which is quite amazing. They developed their palliative care program without the historical baggage that perhaps we have, and I don't mean that in any negative sense. Theirs is purely needs-based. They never worried about diagnosis. These volunteers don't have diagnostic skills. So diagnosis never came into it. All they did was they learned the principles of palliative care, they learned the definition of palliative care, and they looked to identify patients who met those principles, who they felt those principles applied to. And as a consequence of that, their patient profile is quite staggering. They have patients with a range of chronic illnesses. Dementia is a big one. They have patients who have suffered catastrophic injuries, spinal injuries, brain injuries, patients who are post-stroke. I attended a patient, and it's where we actually got to practice logotherapy. I attended a patient who had had a fractured shaft of femur, but because there was no follow-up physiotherapy, she was essentially bedridden despite having really good surgery. She was bedridden and they were trying to mobilise her. As far as they're concerned, she has palliative care needs. When you think palliative care, and that's what they keep saying to me, when you think of what the palliative care principles are about. And whether you agree with that or not is another issue, but that's how they saw it. Now, because they were identifying patients like that, they were identifying programs to be developed arising from those needs. And one of those was rehabilitation. And this blew me away because they see, and I know rehabilitation is becoming very much part and parcel of palliative care, but they do not see the way we distinguish rehabilitation according to specialisms. They see the principles of rehabilitation as speaking to the principles of palliative care. And so they've developed this rehabilitation program. Now bear in mind they don't have the resources, the capacity to kind of engage with the specialist kinds of rehabilitation programs that we might have for people post-spinal injuries, etc. They bring anyone who they think needs rehabilitation into this rehabilitation program. And I met patients who had catastrophic injuries, who were quite literally dying in their beds from neglect, and who were now running their own businesses. And that was as a consequence of the volunteers and getting these volunteers into, or getting these patients into the rehabilitation program. But that's where Suresh Kumar in particular is really seeing the need for that kind of other piece, which I'm really looking forward to Paul's talk, because it's that other piece, it's how we speak to that other dimension of patient needs. And what they were seeing it being addressed through logotherapy. So that's a rehabilitation group, by the way. That's And some of these are in wheelchairs, as you can see, and some of them obviously have infectious diseases. I'm going to leave you with this. So where I stayed in the institute, which was brilliant because I was almost like an ethnographer. I was kind of living the experience, which was absolutely fantastic. And there's a hospice there, so I was kind of with the hospice every evening. But it's adjacent to the medical college. And I was walking through the medical college on the way to the Pain and Palliative Care Clinic one day, and there on a tree was this very simple A4 stuck to the tree. And it's the students telling the students about, look, you've got to get to this. This is students talking to students. It's student volunteers trying to get more students involved. Isn't that amazing? So I'm going to leave it there.
Thank you.